So I'm going to be speaking in the next 15 or so minutes about immune-related adverse events, but I'm starting with pictures of me, in fact, in Nainital and in Hardwar. This was a year and a half ago, seems like decades ago. I really like coming to India, and I would love to come again to your great nation. And really what I would like to do in the next, let's say, 18 minutes is to describe the pathophysiology of immune-mediated side effects of IO drugs, to describe the frequent toxicities, to outline the standard guidelines for management of the toxicities, to somewhat touch upon the more rare and urgent toxicities of treatment and their management, and then maybe share a little bit of my personal experience about how we do this in our chemo daycare. Now, Sawanti, do you think we should more focus on the common side effects or the rare ones? What would be more appropriate for the forum?
I think the rarer ones would, shedding light on the rarer ones briefly, and then just addressing the common ones would be better.
Wonderful, wonderful. So this is what I'll do. And of course, I can leave the slides if anybody wants to further go into them. So really talking about the pathophysiology of immune-mediated side effects, we know that the PD1 ligand pair is not per se, was not evolutionized towards generating immune inhibition in cancer. Rather, it's an evolutionary mechanism that allows normal organs and tissues to induce immune tolerance towards them in the healthy host. And so inhibiting this interaction using anti-PD1 checkpoint inhibitors can break the normal tolerance of immune cells to tissues and organs, thus eliciting a drug-induced inflammatory response, if you will. So if we want to inhibit this pair in the tissue and to generate the desired activation of T cells, then this is in fact the same mechanism that allows for the toxicity. So in general, we can divide the toxicities broadly into two non-immune mediated side effects that would include, as always, hypersensitivity to IV drugs, fever, chills, flu-like symptoms, and fatigue. We all know how to manage these reactions, and I'm not going to be discussing them further. But then the immune-mediated side effects can appear per definition in any tissue or organ in the body. And the important point is that they can appear at any time point during treatment and also after the termination of treatment. I'm just now managing a patient of mine who has finished his anti-PD1 treatment for his head and neck cancer back in April, but then only now developed this hypothyroidism, which I actually missed at the beginning because I thought his fatigue was cancer related rather than to realize that he actually developed hypothyroidism 4 months and more after terminating his immune oncology treatment. Now, of course, the most common organs involved: the skin, the colon, the lung, the endocrine glands, the kidney, and the liver, but we've seen it throughout all organs and systems of the body. And this is really already a few years ago, optimal management of immune-related toxicities. And I've highlighted a few points. Of course, awareness. We must be aware, but our patients must also be aware of these drug toxicity. The patients, the families, because sometimes they would be the ones telling their emergency room physician, listen, but I am getting this thing, and I was told that it can cause, some sort of inflammation, etc. So patient education is key here. We must recognize these toxicities early to start treatment early. And really, I think what we've learned in the last 5 years is really not to hold upon treatment when we're suspecting this toxicity. Early intervention. We're grading the toxicities according to the CTCAE. Of course, I'm not sitting with the little books and giving the exact grades as in the clinical trials, but I do want to know what's the extent of the toxicity, because the whole point of the treatment is according to toxicity. In grade 1, we will give supportive care if it's an antihistamine cream for a rash, if it's loperamide for colitis. But then, of course, once it becomes grade 2 or higher, we're talking about high-grade, high-dose. We are talking about high-dose corticosteroids. And of course, we know that if there's no such thing in immunotherapy as a dose reduction. So the decision we need to make upon termination of the toxicity is whether we want to resume immunotherapy or not, but there's no thing as a dose reduction. So how do we diagnose these things? They're diagnosed clinically. So that means it's based on the characteristic constellation of symptoms and signs. And it's also many times a diagnosis of exclusion. So if we see a nephritis, we see acute renal failure, there's no obstruction to the kidneys, there's no nephrotoxic drug, then you may very well assume that this is an immune-mediated nephritis and start treatment. And same would be for many more of the toxicities. Now, of course, this is the basis of the whole protocol, and the protocol itself is very straightforward. We start with regular, or if you want to call them high dose steroids, which is prednisone or prednisolone at 1 milligrams per kilograms. Sometimes we move, if we don't see enough response, we move to high dose steroids, what some institutions call pulse, which would be at around 2 to 4 milligrams per kilogram of methylprednisolone or the equivalent. And of course, the protocols vary. And then if we don't generate resolution, or if there's deterioration, then there is room for other immunosuppressants such as anti-TNF antibodies, cyclosporine, Cellcept, and so forth. So a little more about the diagnosis. We should always, of course, rule out other causes for toxicity. And sometimes we even use concomitant treatments against several potential diagnoses. For example, we all use steroids and antibiotics when you're not sure if it's a pneumonitis and pneumonia, and many times it can indeed be both. All accompanying symptoms, signs, and abnormalities should, of course, be addressed and corrected. This is our regular, medicinal work. Supportive treatment, never forget, so give the PPIs if you give the steroids, give fluids as needed, pain medication, antihistamines, and etc. And we've also learned that steroid tapering should be long. Now, again, this is a little bit of an art. By now, I've been doing this for a few years, so I know that there's some toxicities that need longer taper than the others, and then also it's a trial and error thing. When I discuss tapering with my patients, I actually tell them, if you go down to the next level, say go from 40 prednisone to 20, and you have the toxicity resume, please go back on your own to the previous dose of steroids, and of course let me know. So really, it's a little bit of a fine-tuning thing. And as a general rule, we do not resume immune-oncology drugs when the dose of prednisone is more than 10 milligrams per kilograms. I do resume when the dose is 10 milligrams, not 10 milligrams per kilogram. When the flat dose is 10 milligrams, we do resume. And in fact, I will tell you this, we have noticed that many patients, when they have a prolonged treatment course with immune-oncology, they actually need their 10 milligrams of prednisone. So many of these patients actually never stop. And this is something I've learned not to worry about at all. I don't think this 10 milligrams of prednisone does not negatively impact the efficacy of the immune-oncology, nor in most cases does it cause significant toxicity. Of course, in diabetics and such, we need to worry, but most people will need their 10 milligrams of prednisone for a sort of general management. And this is one of the guidelines that this talk was taken from, and this is another one from JCO. And I'll quickly run on a few of the toxicities. So skin toxicity. These are, of course, the most common side effects, and they can come in all shapes and forms of pruritus and rash and dermatitis and all of what is here mentioned. And really, most of the events are really low grade, so really things that can be managed, but there are grade 3 to 4 events. They are very rare. The treatment starts with antihistamine, but then we can move on to topical steroids, and then in some patients, we cannot go without oral steroids, which is a little different than the regular dermatology. So my dermatologists, many times they argue with me. They say, but we don't give a systemic prednisone for rashes. And I say, yes, but this is something a little different. And sometimes we have to give systemic prednisone for these types of rashes. And of course, for grade 3 and 4 toxicities, so the pemphigoid type rashes, or the, God forbid, Steven-Johnson's type of rashes, of course, we will never resume immune-oncology. Rarely, in most cases, skin toxicity does not necessitate the cessation of treatment. And of course, we mentioned hypersensitivity reactions, which are general reaction, not necessarily immune-mediated. Then we treat them as others, so steroids and antihistamines, as we know. So this is your typical rash on the immune oncology drugs, and this is a patient who actually managed his rash on his own. He would just elevate his dose of prednisone, and when the rash went away, he would go back to his 10 milligrams of prednisone. And this is, of course, a much more serious rash that we see, and this, of course, would necessitate a whole systemic therapy and would necessitate cessation of treatment. So really, I'm running really quickly to immune-mediated colitis, and of course, colitis or diarrhea is the most common GI toxicity. And this diarrhea could be accompanied by abdominal pain, fever, anal pain, rectal bleeding, nausea, and vomiting. And we should always, of course, search for alternative etiologies. And this is, of course, the management. And not necessarily every colitis has to be admitted. If it's, your grade 2 colitis and you have a good way of managing your patient, then you don't have to necessarily admit him. But of course, if it's a grade 3, you must admit a patient. You must give IV high-dose steroids, and even consider infliximab anti-TNF antibody if the diarrhea does not resolve. And again, we're talking about the slow taper. And just to highlight in bold, the index of suspicion should be high, and steroids should be started rapidly. And this is something we really learned, by experience. I do want to mention there are other immune-mediated GI toxicities such as enteritis, esophagitis, gastritis, ileitis. The whole enteral tract can be involved. This can present with vague symptoms of anorexia, upper abdominal discomfort, nausea, and vomiting. And again, look, this is a mimicker of our patients. So we should do an upper endoscopy if we want to establish a diagnosis, but we must start empirical treatment based on the clinics, not based on the endoscopy. And a rapid resolution of the system will prove and establish the diagnosis. And I call this clinical entity a big masquerader, and we should have it in mind. On the right, you can see a patient of mine who presented with anorexia and food aversion, and it was very weird, and we didn't really know. And he was started on steroids. I couldn't even call it by name. And this is his upper endoscopy. This is his esophagus. He had a very significant inflammation, which was not candida or viral inflammation. It was just an immune-mediated esophagitis, if you will. And he responded to steroids, and his treatment was resumed. His IO treatment was resumed. The lung toxicity, I'm sure you are all familiar with. There are many types of lung toxicities. The most common is the pneumonitis. It's not the only possible lung toxicity. We know that it manifests as mostly as dry, unproductive cough, tachy or dyspnea, cyanosis, fatigue, and fever. But of course, we don't want to get to these points. We want to recognize this at the point of the dry, unproductive cough. And again, it's a clinical diagnosis. We know that it's mainly, you could have a normal X-ray, you could have patchy infiltrates, and rarely do we actually do a bronchoscopy and lavage, only in cases in which the clinics are not straightforward. And again, the treatment is steroids according to grade. And in severe cases, we do give additional anti-inflammatory drugs such as Cellcept or anti-TNF antibodies. So endocrinopathies, another famous toxicity. These appear in up to 10% of the patients. Of course, the thyroid is the most common organ that is associated with this. We can see hypothyroidism, we see hyperthyroidism, and also acute thyroiditis. And additional rare endocrinopathies would include hypophysitis, hypopituitarism, and type 1 diabetes even. So having a 70-year-old non-small cell lung carcinoma patient appearing with a new onset of type 1 diabetes as a result of acute immune-mediated pancreatitis. So I will not go into the clinical. So the clinical presentation of the endocrinopathies, just to say this, that again, the symptoms can be vague and non-specific, right? So we can see headache and extreme tiredness and weight gain or loss and altered mood and irritability. But this can be very similar to the regular symptomatology of our cancer patients. So one must remember these diagnoses. It's very easy to dismiss, to miss these things if we don't think about it. And of course, if we're in an adrenal crisis, it will also be characterized by dehydration, hypotonia. The patient will look like a septic patient, but of course, it will not be sepsis per se, rather a picture of a septic shock, so to speak. And when suspicion arises for a crisis such as this, we should always take the TSH, the cortisol, and additional tests based on the clinical scenario, such as T3, T4, testosterone, prolactin, etc. So I have here a slide about how we monitor thyroid function on immunotherapy. We take TSH every cycle. We have a full battery at baseline and then TSH every cycle. And then, of course, further blood tests upon need, and the management is just as the management of the original disease. Acute thyroiditis rarely necessitates treatment. It's an aberrant thyroid. It's a scenario of aberrant thyroid function tests without any clear pattern. It mandates only follow-up. Where the acute phase will usually turn out to be hypothyroidism. And of course, I did put it here that if we have the constellation of a low TSH, free T3 and free T4, then this should arise the suspicion for hypopituitarism. So again, I'm really short on time, so I don't have time to go into autoimmune-related hypo-cortisolism. Again, symptoms would be vague and non-specific, and we must have a high index of suspicion. The laboratory abnormalities will include low serum cortisol with or without a hyponatremia. And of course, the differential diagnosis would be either a hypophysitis or autoimmune adrenalitis. And we must think of this diagnosis because we must start a treatment as soon as possible with oral prednisolone. I did have a patient about a few weeks ago and coming into clinic very, very tired and fatigued. He had 0 cortisol in his blood. So this is truly an emergency or on the verge of emergency. And of course, we taper the dose until eventually we replace it with hydrocortisone at 24 to 40 milligrams daily or prednisone 10, whatever you're regular to be doing. And of course, if it's a hypophysitis, we replace all hormones along all the axes that are hit. So we have here a slide on adrenalitis and hypophysitis. You can go over that later. So rare immune-related endocrinopathies, diabetes insipidus can occur, very, very rare, and we mentioned the type 1 diabetes. So there's kidney toxicity, serum creatinine elevations, and we should instigate a workup for acute renal failure. But again, at the end of the day, immune-mediated acute renal failure is a clinical diagnosis by exclusion. And if we see response to prednisone, then this will have established the diagnosis. I usually do not admit patients for this. If it's a simple nephritis, then they can get their steroids and just return the following day to clinic to do another creatinine test. Okay, so again, steroids should be tapered slowly. My clinical experience is this may even be not as slow as the pneumonitis. And again, I do not necessarily stop treatment if one developed nephritis on immune oncology. I do not necessarily stop immune oncology. Moving forward to hepatitis, and again, sorry that this is sort of a list of so many toxicities in such a short period of time. So hepatitis would mostly manifest as asymptomatic increase in liver function tests, mainly AST, ALT, and GGT. It's not rare, it can happen. And of course, we always have to do our differential diagnosis, such as progressive disease or other causes of hepatitis. And again, the treatment is steroids. And if there's no resolution, then we need to move forward to other immune suppressants. So just to mention, there are musculo-skeletal toxicities. We've seen arthritis, we've seen myositis, we've seen a polymyalgia-like syndrome, which is pain and stiffness of upper and lower extremities without signs of muscle inflammation or muscle weakness. And just to mention the immune-mediated myocarditis, infiltration of lymphocytes into the cardiac muscle, this is a medical emergency. This can be fatal, and we have to have a clinical suspicion that it. Okay, so I'm wrapping up. These are the neurological toxicities. Again, just so you know that they're out there and we should have them in our minds: autonomic neuropathy, encephalitis, peripheral neuropathy, myasthenia gravis. This is just quickly a list of what are the urgent, emergent immune-mediated side effects. We discussed the toxic epidermal necrolysis, the pneumonitis, myocarditis and myositis, systemic inflammatory response syndrome, hypophysitis can be a medical emergency, adrenal crisis, and encephalitis. So practical aspects, one last slide. Direct history taking by nurse prior admission to receive IO. We ask about rash, about cough, about shortness of breath, and about diarrhea. We take a blood count, liver and kidney function test, and TSH. And if abnormal, we consult a physician. And of course, all the wards in the hospital need to be part of this. We have to have an extreme accessibility of the medical oncologists to this thing. That's me, that's you. We need to be on board because we may get phones like this in the middle of the night. And of course, this is teamwork. We have to advise with our consults, our peers, and our colleagues. This is again the take-home message. I don't have time to go over it. I will end with this by John Steinbeck talking about progress, muscles aching to work, minds aching to create beyond the single need. This is man. For man, unlike any other thing, organic or inorganic in the universe, grows beyond his work, walks up the stairs of his concepts, emerges ahead of his accomplishments. So I'm ending. This is my email, and you're very, very welcome to ask me questions, to consult about cases, to invite me to JAIPUR, all that. So thank you for your attention.
Thank you, Dr. Leibowitz. That was such a wonderful and comprehensive talk.
Very quick. Sorry.
You ran through it in half the time. So really appreciate your time, your effort, and your being involved and accepting to give this talk. So really, what a pleasure for you to have been here to grace us with your presence. I will ask one quick question in interest of time and then move over to the panel discussion. So my question to you is, when you're using two drugs, IO, how do you decide which one to stop when you see a particular toxicity?
Okay, so this is a very good question. Of course, first of all, you stop everything until you have a resolution of the, but then, okay, you ask what to resume. So it's a difficult one. It's a clinical decision. Of course, to get colitis on EP-Nivo, then it's most probably related to EP, and you would stop the EP. What happens if you have pneumonitis? Would you stop the Nivo and then resume the EP? That's a tougher one. So really, it's about, clinical decision and consulting, really. We have our networks of peers and consults, and we discuss these things all day long. I've instigated what I call an immunotherapy forum, which includes all consultants relevant to these cases, so that we're all on board this thing.
You have a name for the forum, I remember.
Yes.
Yes. You have your mascots for the immunotherapy forum. So thank you again. Thanks for gracing us. Thank you.